Hello everyone, my name is Dr. Priti Anand and today I'll be discussing with you an RRR series for MRCG Part 2 students related to oncology. So let's start with a little quote, stay focused and never give up. Let's see some very important questions which are related to oncology, concept based. So this patient is a lady with the 30-year-old who had cervical screening done, which was positive for HR-HPV, which is a primary mode of screening in UK. The cytology, if the HR-HPV becomes positive, the next step in management is usually a cytology, which in this patient showed that there is a mild dyskaryosis. Now, because cytology was abnormal, she was referred for colposcopy and colposcopy was done, but it was found to be normal. Now, colposcopy, if they haven't mentioned, that means it was an adequate colposcopy. That means the full squamocolumnar junction with the older and newer squamocolumnar junction and the full transformation zone was clearly visible. It was done adequate, but it was found to be normal. So what is the next step in her management? In such cases where the colposcopy is adequate and normal, we go back and check the cytology. If the cytology is a mild dyskaryosis, we routinely recall these patients in 36 months because it is still a cytology which is a low-grade dyskaryosis. So it is little okay to go with the only follow-up because they have a high chance to regress to normal and little less chance to go into the pre-cancerous stages causing the CIN abnormalities. So these patients can be put in follow-up. So as we can see in this table also that patient in whom colposcopic examination is done, but colposcopy is adequate, yes. What did the examination says? No CIN seen either on colposcopy or if no CIN is seen in biopsy by chance if it is taken, we will go back and check the cytology, which is if low grade, less than equal to low grade, we just recall these patient in 36 months. So this patient, Deepti, I'll just start again. Deepti?
Yes, ma'am.
Deepti, we'll start again. Just a moment here. We'll start again.
Okay.
Hi everyone, my name is Dr. Preeti and we'll be discussing about the RRR. It is an RRR series for the MRCG Part 2 students for oncology. So I'll start with a little quote, stay focused and never give up. I'll be discussing some concept-based questions for your exam purpose. So let's see one by one. This patient is a 30-year-old woman who has a cervical screening done for HR, which showed that HR-HPV test is positive, which is of course a primary screening method in the UK. When HR-HPV is positive, it is followed by cytology, which shows a mild dyskaryosis in this case. So because cytology was abnormal, she was referred for colposcopy, which was an adequate colposcopy, which means the full transformation zone with the outer and inner squamocolumnar junction was completely visible. But unfortunately, colposcopy didn't report any abnormality and was found to be normal. So what is the next step in her management? We can also see the lead statement over here, which also says which is the single most appropriate answer from the list above. Now, because here the colposcopy is adequate and normal, we'll go back and check the cytology, which says it is a mild dyskaryosis. Now, in such cases, when the colposcopy does not show any abnormality, being adequate, and it is a mild dyskaryosis, we just routinely recall these patients. Remember, this is only for the squamous changes, squamous mild dyskaryotic changes. If in case it is any variety of endocervical changes, then the management will be a little different. So for cytological mild dyskaryotic changes, if you can see over here, we can see that if colposcopy says normal, we recall in 36 months. If colposcopy is normal, but the cytology is a high grade cytology, then we usually refer these patients to the MDT. Okay, or if there is any endocervical changes also, we refer these patients for MDT. It is for endocervical, it is all the type of changes they are referred to MDT. Okay, now second question is a 44 years old lady who has annual smears done. The smear reported to be having atypical endometrial cancerous cells. Okay, so cervical changes were not there. Cervical smear was basically normal, but on the smear they could found that there were endometrial cells which were not normal. They were atypical and were found to be cancerous. So what can be the next appropriate management for this patient? Definitely, she will require a TVS followed by endometrial biopsy. Okay, so these patients, how do we manage? How do we can find the endometrial cells in cervical sample? So if there are normal endometrial cells in cervical sample, not atypical, it is okay if the female is less than 45. We do not do any reporting, nothing is done. If she is more than 45 and up to 12 days of her menses, then also it is okay. But if she is more than 45 and it happens after 12 days of menses, then we have to report it to the gynecologist. It is important to note in any of these conditions, if the patient is on combined hormonal contraception, hormone replacement therapy, IUCD, tamoxifen, then following the above, even for more than 45 days, 45 years after 12 days of menses is also not significant. But if there are atypical cells, then definitely she will require a gynec opinion, TVS followed by the endometrial biopsy. And in this case, it is very much evident she will require a endometrial biopsy to prove what is the reason. Next patient is Mrs. Rachel, 49 years old, 4 live issues, is a school teacher by profession, otherwise fit and healthy, complains of something coming out of introitus from last 8 months. On examination, whole cervix is lying outside the vagina. She is very regular with the smears. Her cervical screening few days back was HR-HPV positive. Later on, cytology was done, which showed endocervical cells. So she was referred for colposcopy, which showed CGIN. For CGIN, they have done a treatment, that is conization, but unfortunately margins were incomplete. So what is the next step in her management, or what is the single most appropriate answer for the question? So because the margins are positive for CGIN, usually if the margins are positive, either re-excision should be done, because CGI you can't leave. It is a very notorious, and it may have deep inside the cancer changes as well. So usually you offer re-excision. Now because this candidate is an ideal candidate, aged, prolapse, so better for this patient is to offer her hysterectomy. Okay, so simple hysterectomy may be considered in CGIN if the fertility is not required. She has already 4 issues. There are positive margins after adequate excision, which is also positive here. The treatment by excision is followed by high-grade cytological abnormality. Patient is unwilling for conservative management. Adequate follow-up screening has not been possible because of cervical stenosis. Patient has other clinical indications for hysterectomy, or invasive disease has been it has been confidently excluded. So any one of them if present, preferably not all, because few of the conditions may be present and one few may not be present, but it is important whenever you are doing hysterectomy, fertility problem should not be there and invasive disease should not be there. Okay, so this patient is basically an ideal candidate to offer her hysterectomy, and simple hysterectomy can be done in this case. Okay, my next question is related to the staging, because endometrial cancer, it is a new staging which has come. So let's see some questions related to it. So in this question, the lead statement says that you have to tell the appropriate stage of the malignancy. You can also get staging questions with regard to the other cancers like cervical cancer or endometrial ovarian cancer. So cervical cancer is often asked in your exam, and because endometrial cancer is a newer one, so be focused and you should know about that as well. Okay, so let's see how we can manage this. So this patient is 38 years old female, underwent staging laparotomy for endometrial cancer. Histological examination shows that it is a clear cell endometrial cancer involving 25% of the myometrium. Now, remember that little older staging was not distributed according to the aggressive and non-aggressive endometrial cancers. Okay. Now here there are 2 varieties of endometrial cancer according to newer staging. One is non-aggressive, one is aggressive. Non-aggressive one uh, is basically endometrial adenocarcinoma, which is grade 1, grade 2. Okay, those are non-aggressive ones. Whereas aggressive ones, apart from it, all EECs grade 3 or all other varieties or other histological varieties are the aggressive ones. Now, if we see if it was uh, EEC grade 1, grade 2, this would have been very early cancer, either localized to myometrium, less than 50% of localized to endometrium, but less than 50% of the myometrium involved. But now, because it is clear cell adenocarcinoma, it becomes stage 2C. Okay. So aggressive histological type with any myometrial involvement is actually stage 2C cancer. Okay. So please remember, now it is not only restricted just because it is less than 50% myometrium, it has to be stage 1A. It is now differentiated on the basis of aggressive and non-aggressive variety. So aggressive varieties with any involvement of myometrium is always stage 2C. Second question is, woman has been referred for colposcopy to the colposcopy clinic with the smears reporting severe dyskaryosis, and colposcopy showed invasive disease, which was confirmed by biopsy. Later on, MRI was done, which showed a 3 centimeter cervical tumor with the involvement of upper third, 1/3 of vagina, vaginal wall, and the vaginal fornices, but no parametrial involvement. Examination under anesthesia confirms this. So, what is the most appropriate stage? Now, because it is now not localized to cervix, so it is beyond stage 1. So it is stage 2 because it is now beyond cervix. Any cervical cancer which is involving upper 2/3 of vaginal wall is stage 2A. And because it is still less than 4 centimeters in size, so it is still 2A1. Okay. So as we can see over here, involvement of upper 2/3 of vagina without parametrial involvement is 2A. And if it is less than 4 centimeters in size, it is 2A. Okay, my next question is a patient with the laparoscopic left ovarian cystectomy done considering it was a dermoid. Later on, it came out to be the serous adenocarcinoma, which was confined to ovary and not extending to the ovarian capsule. But during operation, when they were doing it, they got the cyst ruptured intraoperatively. Now, because it was confined to the ovary, if everything was okay, it was have been stage 1A. But now, because it has ruptured intraoperatively, it automatically has upgraded to stage 1C. So 1C stage is very important in ovarian cancer, where the tumor is located to one or both the ovary. Either there is a surgical spill, like in this case, intraoperative rupture, so it will become C1. Capsule rupture or tumor on the ovarian surface is present, it is 1C2, and malignant cells in ascitic fluid or positive washings is 1C3. Okay, again, stage 1C for ovarian cancer is very important. Now let's see some questions which says that which of the following investigations are most suitable for these candidates? Pick up the single best answer. Each option can be used once, more than once, or not at all. So let's see these questions. So 65 years old postmenopausal nullipara women is referred to by her general practitioner with 9 months history of constant sensation of bloating and indigestion. She's tried some herbal and medical management which was not helping her. The general practitioner also found a pelvic mass on examination. She was referred for urgently to a secondary care. She has a personal history of endometriosis, but no significant family history. Following history and examination, there was a suspicion of ovarian tumor. RMI calculated 960. What is the further investigation done in her case? So because they have calculated RMI, that means CA125 and USG was done. Now it was confirmed the RMI is more than 200. It is some type of malignancy. So before doing any surgical staging, for ovarian cancer, it is mandatory to do a CT scan, abdomen and pelvis in detail. Okay, so as to know the local spread and the distance spread of the cancer and whether the lymph nodes, etc., has been involved or not. If the patient had uterine sarcoma and it was diagnosed when abdominal hysterectomy was done for fibroid. So abdominal hysterectomy was done for considering that it is a fibroid. Later on in histopathology, it came out to be the sarcoma. Now, what needs to be done as an investigation before you perform any full surgery? So please remember, for the locals understanding whether there has been a local spread, detailed local evaluation or staging, it is very important to do MRI abdomen and pelvis in the first site. Okay. For distance metastasis, we may require PET scan to be done, but initially first line of management, first line of investigation for these patients will be MRI abdomen pelvis. So this is also a reference which also says that MRI is highly effective in assessing the local extent spread to the adjacent organs and lymph nodes. So it is crucial for planning the surgical interventions. It remains still the gold standard for detailed and comprehensive evaluation and capabilities. This is again the reference. Finally, what is the best investigation to identify extra pelvic disease in patients in whom you are planning to do a pelvic examination for recurrent vaginal gynecological cancers? So, very important question. Now, here, before pelvic examination to be done, it is very important you do a PET scan. Okay. Even some, they also report that you need to do so the next question says that what is the best investigation to identify an extra pelvic disease in female who is considering a pelvic examination for recurrent gynecological cancer? Now this is a very important question. Now again, now we suspect that there can be there is a reoccurrence which requires a pelvic examination. It automatically comes in mind. Then why not MRI abdomen pelvis? They would have already done it. Now for pelvic, before doing pelvic examination, it is very important to rule out the distance metastasis, which is a contraindication for pelvic examinative surgeries. Okay, so here PET CT will be done as a before the pelvic examination. For the local spread and the extension, they would have already done MRI, but for the pelvic examination, you need to do. Even the diagnostic laparoscopy is proposed to be done before the pelvic examinative surgeries to be done. Okay. Okay. My next question says a 56 years old woman diagnosed to have ovarian cancer. The spread is up to the fallopian tube. Now, spread is up to the fallopian tube means it is a stage 2 cancer. And the lead statement says that you need to tell the appropriate answer from the above list, which is a stage. Usually it's not given. So stage is second. What will be the management? So for all the ovarian cancer, the standard management is a surgical staging. So we will do a staging laparotomy in this case. Okay, and 56 years old female who has had and undergone a staging laparotomy is now noticed to have a epithelial ovarian cancer with retroperitoneum lymph node involvement. What is the appropriate treatment option for this patient? Now, definitely it is stage third, and after the surgical staging, any stage 2 cancers beyond stage 2 and beyond, after the surgical staging, dual agent chemotherapy is given. So 6 cycles, 3 to 6 cycles of carboplatin and paclitaxel will be given in this case. Okay, let's see some SVAs as well. So there is a 33 years old lady, cervical skinning showed severe dyskaryosis, referred to a colposcopy. Colposcopy directed treatment was done. Biopsy when came as a histopathology, it came out to be stage 1A1 cancer with SYN3 extending to the deep lateral margins. What is the treatment option? So there is two things. First thing, it was treated considering that it is basically a SYN pathology, but it came out to be stage 1A1 cancer. Now they are also seeing that there is a positive margins for SYN3. So what do they say? That if you are treating stage 1A1 cancer with the local treatment measures like leads, or if you have done a conization, and if you find that endocervical and deep lateral margins are free of both SYN and invasive disease, re-excision is not required and nothing is done. They just put these patients on follow-up. But if the invasive lesion is excised, but SYN extends only to deep lateral margins or endocervical, then a repeat excision should be performed to confirm the complete excision. Okay, so if ectocervical margin is involved, we'll not do anything. But if deep lateral or endocervical margins are involved, then definitely we will re-excise it. A 16 years old girl is coming for HPV vaccine. Which of the following is a correct statement? So both HPV vaccines administered in UK are quadrivalent. So there is a dual bivalent also, quadrivalent and monovalent also. HPV vaccination can be given to children and adolescents 9 to 15 and adult age 16 to 25. This is correct statement. HPV vaccines aim to target 8, 11, 16, 18. No, 6, 11, 16 and 18. So it is a wrong statement. 2 prophylactic vaccines have been developed with the aim to avert 90% of the squamous cell cancer by HPV prevention. So its efficacy is 99%. 2 prophylactic vaccinations. So with the age range up till 50, it is 2. Above 15 and above is basically 3 doses. Single dose vaccine is delivered? No, they are 2 doses. So 9 to 14, they give 2 doses. 15 to 25, they give 3 doses. A 75-year-old lady with the diabetes from 10 years, which is controlled. She is otherwise fit and well, complains of sore and itchy vulva since 2 years. GP has examined her. She is referred to oncologist. Her examination findings are 5 into 4 centimeter ulcerated lesion above the clitoris, which bleeds on touch. There is no enlarged nodes in groin on palpation. What is the next step in her management? Deepti, just a moment, dear. So it is a 75 years old lady with a controlled diabetes since 10 years and glaucoma. She is otherwise fit and well. She complains of sore and itchy vulva since 2 years. GP has examined her. Oncologist has given his examination findings as 5 into 4 centimeter ulcerated lesion. So she is with the oncologist now, and there is no enlarged nodes in the on palpation. So what will be the next step in management? Because this patient is already a referred patient with the oncologist, and the clear-cut case of the vulval cancer with the rolled over edges and ulcerated lesion which has been itchy from last 2 years, not healing, is requires a biopsy. So it will be an incisional biopsy from the edge of the ulcer. Remember, always a biopsy in vulval cancer is an incisional biopsy. It is from the edge of the ulcer, never from the center. Or it can be the Keys punch biopsy. Multiple punch biopsies can be taken with the help of Keys punch biopsy blade. 46 years old lady had a total hysterectomy done. Hysterectomized sample histopathology showed CIN3, but it was incompletely excised. She has now come after 6 months. What is your monitoring to be done? Now, these patients with the histopathology showing the SIN3 pathology, uh, they are usually checked with a walled smear for HR-HPV test, which is done 6 months after the surgery, then 12 months, and then 24 months. 6 months after the surgery, then annually then 12 months, and then annually they do it till the age of 65 years or 10 years, whichever is later, because it is SIN3. So Walt HR-HPV, because she is coming after 6 months from the surgery, so Walt HR-HPV will be done today. So 6 months from the surgery means today she will be doing first HR-HPV, then after 6 months, and then annually till the age of 65 years or uh, till the for the next 9 years, whichever is later, to complete a 10-year follow-up. Okay, so remember this. So we can just discuss a little bit on this in detail also. So yes, the same patient with the hysterectomized sample with the SIN3 was completely excised. Now, if it is a completely excised lesion for any SIN pathology, only one wall smear for HR-HPV is done after 6 months of surgery. Okay, please remember. So, just a quick review that if SIN pathology is completely excised in hysterectomized sample, one wall HR-HPV will be done at 6 months. If it is negative, you discharge the patient. If it is positive, you refer for colposcopy. If SIN pathologies are incompletely excised, if it was SIN1 pathology, then you do a Walt HR-HPV testing 6, 12, and 24 months. If it is SIN2, SIN3 pathology, then you do it at 6 months, 12 months, and annually for 9 years until the age of 65 or to complete a whole 10 years of follow-up, whichever is later. Okay, 30 years old lady with cervical screening, HR-HPV positive, cytology report showed mild dyskaryosis. Colposcopy done was showing SIN1 pathology. What is next? So SIN1 pathology has a high chance to going back into the normal. So these patients are just put on regular follow-up. So it will be a recall in 1 year. So if cytology of this patient with HR-HPV test shows HR-HPV is positive, cytology is abnormal, the patient is referred for colposcopy. If colposcopy says that it is SIN1 pathology, usually we do a recall in 1 year. Some patients of SIN1, because they are every follow-up, they check whether it is regressing or not. And even after 2 years, it is not regressing. At least a biopsy should be considered. And if it still shows SIN1 pathology, annual surveillance should be done. A 55-year-old lady postmenopausal attends the gynecological oncology clinic with some questions regarding her personal risk of ovarian cancer, as she believes she has a high risk of developing ovarian cancer due to the family history. As she has a friend who suffered ovarian cancer and now her daughter is having the same. So she has done a lot of research and she wants to know what is the next step in the management and what will you advise her. Now, this patient has some bad history in the family. Also, she has heard something from her friend. So because she has own a family history of ovarian cancer, it is very important first step to give her a genetic counseling to the patient. Okay. So this patient will receive a genetic counseling for BRCA1 and BRCA2 testing. Now, in case if BRCA1 screening becomes positive for this patient, she will be offered risk-reducing bilateral salpingo-oophorectomy by the age of 35, which should ideally be done because she is already 55. It should be done right away. So earliest, they also ask in exam, what is the age offered for BRCA positive patients to undergo RRBSO. So it is 35 years. Okay. In case they refuse the surgery, then you can put them on surveillance, which is basically 6 monthly you do a C125 and TVS for the pelvic organs. That is uterus and bilateral adnexes are seeing the ovaries. If the patient of BRCA positive they are at risk of two type of cancers. One is the breast cancer, other is the ovarian cancer. Again, this is a very important point for your exam purpose. What type of breast cancers? It is invasive ductal cancer. What type of ovarian cancer? It is high grade serous cancers. Okay, so this patient is nullipara, 66 years old, vaginal bleeding and abdominal pain from last 2 months. She has noticed some distension as well. The uterus was enlarged and endometrial biopsy was done, which showed it is an endometrioid adenocarcinoma. MRI showed 3/4 of the myometrial invasion. She underwent THBSO with lymphadenectomy and after MTT discussion and histopathology shows it is a low grade EEC cancer involving 2/3 of the myometrium and lymph nodes are negative. Now, because it is a non-aggressive variety and it is involving 2/3 of the myometrium, you can say that the stage for this cancer becomes stage 1B. And usually for these patients, you at least after the surgery give them the post-operative vaginal brachytherapy. Okay, so let's see what we have just discussed earlier also. Non-aggressive cancers are of two varieties, EEC grade 1 and grade 2. Rest all are high grade. Now, if the non-aggressive variety, which is limited, less than half of the myometrium is involved, it is still stage 1A. When it involves half or more than half of the myometrium, it becomes 1B. So you can see here 2/3 of the myometrium is involved. Okay, so it becomes 1B. So these patients who have stage 1A grade 1 cancers, grade 1, grade 2, after the surgery, they do not require anything. Stage 1A grade 3 or stage 1B grade 1, grade 2 tumors, after the surgery, they require vaginal brachytherapy. And high risk, apart from these, all the patients, stage 1B grade 3 and the all aggressive variety, will require both external beam radiotherapy and vaginal brachytherapy. So this is a 35 years old lady, 32 weeks pregnant with stage 1B1 cervical cancer. So in pregnancy, when the patient has cancer, you first need to check what stage of pregnancy she is. If it is stage 1A1 cancer, you treat her by conization in between 14 to 20 weeks. If it is stage 1A2 or 1B1 cervical cancer, if it is less than 22 weeks, you ask them to undergo the pelvic lymph node dissection. If they are positive, you terminate the pregnancy and do the treatment. If they are negative, then you can either postpone the surgery or any treatment after delivery, or at least a simple tracheotomy can be done. If it is more than 22 weeks, you either give a neoadjuvant chemotherapy or you delay the treatment after delivery. Now, because it is stage 1B1 beyond 22 weeks near to the delivery, so you will first do a cesarean to deliver the baby, followed by the complete surgery. Okay, and remember, these patients will never be delivered at term. So that is why B option is wrong. As soon as you think that the fetal maturity is achieved in between 34 to 36 weeks, you will deliver the baby and perform the rest of the management for the cervical cancer. A 13-year-old lady, a girl, is there with an ovarian tumor, and on analysis, it is seen that beta Hg and CA125 are normal, but alpha fetoprotein and lactase dehydrogenase is positive. So what type of ovarian tumor it is? So wherever AFP is increased, it is very pathognomic and very important tumor marker for the yolk sac tumor. Okay, so you can see in this, and basically it is dysgerminoma. You see only LDH is increased. In yolk sac tumor or endodermal sinus tumor, you can see alpha fetoprotein and LDH both are raised. Okay, so this is all from my side with regard to oncology module for MRCOG Part 2 students and the RRR series from the StudyMEDIC. I hope this helps you. If you have any doubts, please message and comment. I'll be really happy to help you. Thank you, dear. Thank you, everybody, and thank you so much.